Wonderful. Thank you, Erin. All right, John, I think we are ready to get started.
Great. Thank you, Candace. Good morning, everyone. We're really glad you're here. Since we're being recorded, this is April 27th in the morning, and we're doing the private duty nursing rules review. We are being recorded, so just to remind everyone that we urge you to make conscious choices about the protected health information protecting yours and your clients. And so this will be recorded. Please bear that in mind. Please use the chat box for comments and questions, which will be monitored by staff, I'm told, and be responded to. And when those moments come in the meeting, if you want to speak verbally and we do the list speakers queue, you can raise your hand. There's an icon of a hand down at the bottom of the webinar. I will ask people who are on the phone only to unmute by pressing *6 and giving you their name for the queue. You can also type your name in the chat if you need to, but I would ask if you're on the webinar, if you could raise your hand, that would be really handy. We have a large group, getting larger. The slides are available, and you see the link for that page right there on the screen. And again, press 6 to unmute or mute your phone if you're listening by phone. If you're by computer audio, obviously you will know how to do that. And there are resources online, and you have the link there for that. Next slide, please. Thanks. Just before I hand it over, I want to say that we are asking people to be mindful of how we are with each other, rules of engagement. There are many strong feelings that people have about rules and the review of rules and changing them and services in this area. So we ask you to just let's remember we all have positive intention here and be mindful of how we are acting toward each other in this process. Thank you. I'm turning this over back to Candace or Erin.
It's me. Thank you, John. Thank you all so much for joining us today. My name is Candace Bailey, and I am the HCPF Division Director. And my team manages all of the home and community-based benefits. In addition to some state-funded only benefits, we also oversee the policy for the private duty nursing benefit and all of the long-term home health benefits as well. We are so excited to have you all here today with us. This is our second meeting around the rule revisions specific to private duty nursing. So thank you all. The last meeting was incredibly helpful and productive. You all had some amazing feedback, so I really, really appreciate it. And I'm so excited to see many faces again today. Next slide, please. So just a quick reminder, our purpose for this and future meetings around this is really to engage with you all. It's to engage and understand and collaborate on ways that we can revise our regulations so that they better meet the needs of everybody. Next slide, please. Here is our agenda for the day. We have a lot of slides and a lot on the agenda, just so you all know. So we're going to kind of go through it as best as we can. This is not going to be the only time for feedback, obviously, but I just want to make sure that you all are aware there are a lot of slides. And I do believe Erin put the link for those slides in the chat as well. So let's go to the next slide here. Housekeeping. So just a couple of little items here that I want to remind folks. If you're not speaking, please make sure you're muted. Background noise comes across way louder than you realize it does. And it's really distracting and makes it hard for anybody else to actually listen and engage. And so if you could make sure that you are muting yourself when you are not speaking, that would be great. And then raise your hand if you are looking to speak. We can certainly call on that when we get to the various points. Use the chat box, enter questions and comments. Please, please, please do not disclose any protected health information, PHI. If you do so, we actually can't post this recording. And it's really critical that everybody has access to this recording and to this presentation, just like everybody else. Not everybody's schedule works the same. Not everybody is able to attend today. And we really would like to be able to post this. However, if you disclose any sort of PHI, we cannot post this recording. And that would be really, really unfortunate. So please keep that in mind. Even if you're comfortable with it, we legally cannot. and therefore you take away somebody else's ability to be able to listen. So please keep that in mind. So over on the right, there's other ways that you can send us questions, comments, suggestions. The rules themselves are actually posted. The webinars are posted. The slide decks are posted. Everything is up online, and Aaron put that link in the chat box for you. Next slide, please. Great. Thank you so much, Aaron, for posting all that information. Just to give you a little overview of what we are looking to do here. So here is the process. So really, we're looking to conduct our meetings throughout the majority of this year, quite frankly, because this is a really meaty topic and there's a lot to discuss. And so we are going to hold many stakeholder meetings to really engage and figure out the best way that we can make adjustments. We will then go through the clearance process and plan to present to the Medical Services Board with the effective date being likely sometime in spring 2024. All right, next slide. So here are our goals. So just as a reminder, a lot of these slides are similar to the last one, just so you all know. But just as a reminder, these are our goals for this process, for these rules. It's really to conduct our thorough review and update all of our rules for private duty nursing. So the idea is a lot of these rules haven't been able to be updated for a long time, so it's time. Let's do it. Let's get some of the old archaic language out of there, and let's get some new language in there that makes more sense. We're hoping to collaborate with you all to make sure that language is clear so that we all have the same understanding going forward. We can identify areas that need edits, rephrasing, just general clarification, all of that kind of stuff. So some examples are adding relevant definitions to the rules and then using best practices to help clarify the process, because sometimes that makes it a little bit easier to understand. Next slide, please. Great. So this is a general overview of the current structure. So this is what the regulations in the 10 CCR 2505, I'm not going to say it all because that's boring. You can read it. But this is what the general structure is within that regulatory framework. So we have our definitions, the benefit, limitations. So this is what it looks like. Next slide, please. All right. So continuing just the background and some general things here. The overview of the PN rules. Again, we're going to address each section of the rule or a topic independently. So we are not planning to bring, and we haven't been bringing the entire rule to you all to look at once, because that is just too much. And it doesn't allow for enough engagement and back and forth and communication per each section. And so we are coming section by section, meeting by meeting to discuss these areas. So today, we are actually going to be focusing on the remaining PAR components, which includes a description of the submission process, the third-party utilization management contractor, and the process there. We'll also go into reimbursement today as well. Next slide. Okay. So just some general considerations. So some things that are important for you all to keep in mind as we go through this process here is the language and the concepts, the things that we're talking about, the things that are presented, they're not final. This is all just ideas proposed, like nothing is final, nothing is out the door. This is the way it is. Nothing is being changed 100% today. This is a chance for us to discuss things, bring you guys ideas, you guys to present ideas to us, and then we can move forward. We are documenting all of the feedback and the ideas. So everything that comes through the chat, we're capturing because it's recorded. We're capturing the verbal comments as well. We're documenting all of our emails that we receive, all of it. Certain words are going to be changed throughout the document. Things like client will be changed to member. That's just going to happen. We have adjusted our language. We don't use the word client anymore. We use the word member. In some cases, we're just reorganizing sections to improve readability and clarity. So it's not really different. It's just adjusting the way that it flows. It makes it a lot easier. We're going to add definitions for common terms, spell out acronyms the first time they're used to make it much more clear. And then in general, we really, really want your feedback. We really want your participation. So we look really forward to that. All right, that is all of my preamble, all of my beginning sentences, all of my background that I have for you on this. Before I jump into the very first change that we're going to go over today, are there any questions or comments about the process, about today's meeting that I can answer?
So this is John. If you do have a question or comment, if you can raise your hand in the webinar, or if you are on the phone only, you can unmute right now by pressing *6 to give me your name for the queue. Thanks, Katie. We'll get to you. Anyone else?
John, I see several comments in the chat from Galia. Why don't we go to those that are speaking first, and then I can jump into Galia's comments?
Hello.
Very good. Katie, go ahead, please.
Hey there. This is Katie Wallet. I'm an attorney at Colorado Center on Law and Policy. Can you guys hear me?
Yes, thank you, Katie.
Okay, just checking. Thanks. And I've talked to you a little bit about this, Candace, via email, but I was just hoping you could talk a little bit about how the responses and suggestions and comments and questions will be logged and then shared afterward. And along with, I think there was a comment earlier about sort of meeting minutes and how can we expect to know what the department is doing with suggestions, comments, and questions that come up in these meetings. If you could speak to that, I appreciate it. Thanks.
Yeah, that's great. And thank you. That is actually one of the comments and questions from Galia. So thank you, Katie. So the Erin, is the listening log posted right now?
The team is working on it. There's some accessibility stuff they're trying to figure out. So
okay.
Soon.
Thank you. So what we have done is we put together what we lovingly call a listening log. Because we like our terms and acronyms. And what it does is it actually takes all of the comments, how we received them, whether it was in the meeting, whether it was an email, and then we have a department response of, that's a great suggestion, thank you so much, we'll include that, or, that's a topic for future discussion. We look forward to bringing that up and discussing it with a larger stakeholder group, or we legally can't change that, or whatever the response might be, right? And so how we are incorporating that is actually posted in that listening log. And to Erin's point, we are working on getting that posted to the website. It'll be on that same link that Erin shared earlier where everything else is posted. We just have to ensure that it is accessible. And because of the format and the size of the document, because there's a lot in there, it takes a lot longer to be able to adjust it to be accessible. So we are hoping that will be up. I'm hoping any minute. I think realistic is sometime today. And then what we will do from there going forward is that log will stay posted. We will then add to that existing log. So everything will stay in that same log, if you will. It'll have the dates and everything. So any new information that comes in, any new comments, any new meetings we have, anything like that, or feedback, will all be added to that log with our responses. I hope that makes sense. Great.
Thank you.
Yeah, thank you, Katie. I appreciate that. And John, do you want me to? Yep, I see Christy's hand. Do you want me to go to that, or do you want me to address the comments first?
I think it's up to you. Certainly, you mentioned that you were going to address some comments. Perhaps you can do that, and we'll get to Christy.
Great, that sounds good. Christy will be right with you. All right, so the first comment from Galia was around meeting minutes and changes. So I think I just covered all of that with the listening log and how that is going to work. Then she asks, was pediatric and adult PDN policy, I think she meant changes, separated? No, and that is also addressed in the listening log. So PDN is one benefit. And what we did in the regulations is, or what we plan to do, because we haven't actually made any changes yet, is to just identify where there is a difference between the two. Going on down, Galia mentions that we stated that HCPF stated they will delete the phrase continuous nursing because that implies only 24/7. So we actually didn't agree to delete the word continuous. We had a discussion around the word continuous and mentioned that we are going to have to bring that back to discuss further with the additional stakeholders. So I heard a couple of people, but then I also have heard other people say that the word continuous is appropriate. So there was no agreement to actually delete that term. Okay, and then Christy, it looks like maybe you put your comment in the chat. This is for pediatric, it's for both. I answered her question. Yay. Glad to hear. So this is for the rule in its entirety, private duty nursing, and includes both adults and children. Great. Any other comments before we get started on the proposed changes for this meeting? All right, not seeing any. John, I'm going to go ahead and move us forward if that's okay.
You bet. Okay.
Great. Okay, so I am going to use the same format that I did last time, where on the left-hand side of the screen is the current rule language, and it's labeled that way. So this is what is currently and how it currently reads in the regulations. And then the proposed changes are going to be on the right. And just as a reminder, sections 8.540.7A through C was actually reviewed in our first meeting, which was held on February 23rd. So just as a reminder, and now we are on part D going forward. So, okay. So the first change here is really around the utilization review and what providers must submit. Providers must submit requests for prior authorization, and it outlines that they have 10 days, and then the URC will review the request for prior authorization according to the terms outlined in their contract. So this is pretty specific as far as calling out their contract, because we often have contract changes. We often actually enhance or increase the timelines or decrease the timelines that our reviewers have. And so rather than having to change the contract and then also regulations, it has to be in accordance with our contract. The actual process itself and what it looks like will be posted online. We are going to include that in, I'm not sure if we'll put it in our FAQ section because it might be a little long, or if we'll create its own section, but we are going to make sure that that information is completely transparent and visible for you all, so that you can see what the contract looks like. What do we require out of them? How does this look? What does a peer-to-peer mean? What is their turnaround time on that? All of that will be posted online, which will help with the understanding and keep us from having to put contract language in our regulations. Okay, next slide, please. And I'll go through, oh, go ahead, Katie.
Sorry, I thought I would just comment on this one before you go to the next slide, if that's okay. I had a couple concerns with that, what you were just talking about putting all of that in the contract, and I wanted to sort of outline them. One piece is certainly anything related to how we're determining what's medically necessary has to have this ascertainable standard right from the federal law. So I appreciate that. There may be some deliverables or reports or timeliness that you're saying needs to be in the contract as opposed to in the rule.
Right.
But I just want to make sure, like, I would definitely want to add in language here that says that this contract has to be consistent with federal and state law regarding the medical criteria. So I would definitely add that in. But I also think there's 3 concerns that come up when we are taking language from the rules and putting it in the contract, because the edit here takes out a lot of the language. And I think the idea is to put it in the contract to make it easier, which I appreciate. But there's no stakeholder engagement in the creation of that contract. Like, we might be able to see the RFP, but then the contract is negotiated between HCPF's lawyers and the URC's lawyers sort of behind closed doors. And so we have no way of sort of being involved in that. And I think the second piece is enforcement, right? How do you enforce a contract? The only way to enforce a contract is one party suing the other party, right? And so again, like, unlike a rule, where we have these enforceability provisions about sort of the application of those rules, there's no enforcement mechanism if the URC doesn't do what the contract says. And then the third piece is, I'm curious about how the ALJs are going to handle that, right? Contracts can change mid-year, change year by year. And if there's ALJ meaning administrative law judge in the Office of Administrative Courts, the OIC, trying not to use my acronyms here. I'm just concerned about how the judges will know what's in that contract, which can change year to year. And again, it doesn't go through the same stakeholder engagement and long process that rules do. So I'm really concerned about sort of the impact of this last piece without it being clear why we're taking certain things out of rule and putting it in a contract, which again is sort of more behind closed doors.
I appreciate that. And Michelle has her hand raised to help us and answer some of the questions around the contract itself. I will tell you too, Katie, that this is the first piece. And so there are still a lot of components that are to come that are still in regulation and that will remain in regulation that will be specific for members, for the ALJ, and things like that. So I'll let Michelle jump in and talk about, I think she probably wants to talk about enforceability of the contract, but I just want to remind you, this is the first slide out of many, many slides that are going to outline what we have in regulations. So go ahead, Michelle. Oh, you're on mute, Michelle.
You know, I think I'd have that down by now, but thanks for bringing that up, Katie. And I like kind of taking this in steps. So some of this too, I want to make sure we put in writing, but a couple of things. I saw a couple comments. All department contracts are public. There is a request process. And so I think what we can do is maybe we bring that, I should have that memorized. It goes through our purchasing and contracting division, but every contract with the department is public. You just have to request it in the way that is required per the state purchasing regulations, but we can absolutely give everybody that information. There is, so you're correct. So this contract was done in an ITN and an invitation to negotiate, which is slightly different than an RFP, which is a request for proposals. That being said, what we're going to do is a couple, I'm thinking of it in parts. So what we're talking about here are exact contract language and turnaround time. So for example, we have a rule separate from the PDN rule that states PARs cannot exceed 10 days, right? So that's where you're talking about where are we making sure that they follow that. So we're following current rules, to your point, federal regulations, absolutely. So that, but we want to kind of outline for you, this is what the turnaround time is for the initial review. This is how long a pen is pended for. This is what a pen means. This is a peer-to-peer. This is a reconsideration. This is it, and kind of define those and then put these turnaround times. Now, all of our turnaround times are within the 10 or less. I am also looking at options to increase those or change those. And I will just let you know that we're trying to do it by benefit. I think it's important that certain reviews, we should allow the vendor to take longer, more pages to review, longer clinical records. Whereas when I'm looking at diagnostic imaging, I'm trying to keep that in 2 days or less. So I want to be clear that we're being very specific to try to lower the turnaround time as much as possible, but yet recognize which ones take longer. So there's a lot of thought that goes into that. And I'm continuing to try to do that. Also stuff like peer-to-peers. Getting a hold of physician, hard, their schedules are hard. So I make a lot of considerations around waiving that. If a provider comes back later and is outside the time frame, I'm going to try to get that taken care of again. So some of this like a retrospective review. So again, I think it's really important that you all see the terms and we will be very transparent with those. When it comes to enforcement, I will tell you that this falls under my clinical operations and I have an entire team. And we look at every single turnaround time. We're pulling pens. We are auditing. We are doing all of that. And I would say that from a department, you're not wrong that sometimes at some point it may get to a lawyer. That's the world of contracts. But I will tell you that in most, actually, I think in all contracts of the department that fall within this type of scope of work. So I want to be careful. There is a PIP, Performance Improvement Plan, which is followed by a CAP, Corrective Action Plan. And a CAP is a very big deal to vendors. So we don't have to go down to, I think it's what's it called, invitation to cure is when you get to that last stage where you're talking about the lawyers. But those CAPs have to be a part of when they bid in other contracts in other states. So a CAP becomes public knowledge and it actually can hurt their business if they are trying to expand. So that's kind of some of the tools the department has. And I'm happy to also include some of that in the FAQs if you guys think it would be helpful. And then I think you're also talking about, and I'll take that back, and I think this will be a good discussion where we're talking about also where, I think you're getting down to in here, where are we going to outline the requirements in the contract versus the requirements of the clinical documentation and the criteria. So I'm kind of separating these out, but absolutely taking that back. And then I forget Candace too, but I think we're going to have that outlined and then we can bring that up at that time. So I don't know, Katie, that was, I just talked for a really long time and hopefully I touched on a few things. We'll take the rest back and then I need to get some of this in writing, but is there anything I missed that I need to take back?
Michelle, I think you hit most of it. Katie can let us know if she thinks that we missed anything. I will also say Galia is asking for your current position and title.
Oh.
Michelle is our Chief Nursing Officer within the department.
Yeah, I've got a few. So, and for background, for anybody that doesn't remember me, I'm actually the person that was hired and I created the pediatric assessment tool for the department 10 years ago. I have since, I'm the Chief Nursing Officer for the department. The UM program moved into my clinical operations division less than a year ago. It moved under the clinical team. I'm also the Deputy Director for the Cost Control and Quality Improvement Office. So been with the department 10 years. I've been a nurse for almost 30, and 10 of that I worked in the pediatric ICU and I did pediatric trauma. So that's a little quick snippet of my background. Thanks for reminding me. Thank you.
Thank you, Michelle. Katie, you have another follow-up question?
Yeah, just a quick one. Let me put my hand down. There we go. Which was just, I really appreciate your response, Michelle, and I appreciate, the department's efforts to make sure that the contracts are public. It is too bad that you have to request them, but I understand that's a totally different regulation that you can't, change. I think my concern with this language for number 2 is that it's just so broad. It doesn't say what you said out loud, that this will not include the medical criteria, and that this only is about the timing, or this only is about a certain thing. And I think with it being so broad, it's just hard to know how that will be applied, 20 years down the road. And then the other piece I would say is just, I also really appreciate hearing kind of what your team does in terms of enforcement of the contract. And my point was only that the public and the members have no role in that. And unlike with the rulemaking, where here we are in this meeting having a stakeholder process, the contract is hammered out between, the parties. And then there's no way for us to, if a member has a problem and is going to an appeals, they can't say, here's what the regulation says, and the URC isn't following it. And that's my concern. So I just want to make sure that this is really clear that we're only talking about these specific things. And again, just thinking also about contracts change year to year, change mid-year, and how that is actually going to work. That's just just wanted to highlight that. Thanks.
You know what? And I actually, it's very bizarre, but even as the nurse, I am heavily involved. As our purchasing and contracting people will tell you, I am very, very, very specific about contracts. And it's one of my favorite things to work on. And so I think, Candace, this is a good question. I cannot promise this, but I thought I heard some discussions around stakeholder engagement or how that looks on selections. I'm going to ask our purchasing and contract team to see if they can also supply some information about roles and where roles could be. How do they contact? What is the request? Are there opportunities, to your point, for stakeholders? I'm going to use that loosely, to be involved. I'm going to take that back as well.
Thank you, Michelle. And John, I'm guessing you're going to suggest that we move forward because we have not made it very far. So
what? Diplomatically ask if we should do that.
Yes,
That's
please.
all.
Yes, please. I appreciate that. And Katie, I would encourage you, take a look at the rest of the language as well, and perhaps some of your concerns will be alleviated. But again, if you have specific changes, feel free to send those to us because we are looking for those changes for sure. Okay, next slide. Let's go a couple of slides, and then I'll pause again for comments and feedback because I want to make sure that we get through this. So the next one really is just a renumbering of some of the items. So it looks very different, but really it's just a renumbering and reordering. One of the key things is that we want to make sure that providers actually only request services that are covered. So please don't mislead members in requesting and offering to request services that just are not a covered benefit. Additionally, written notification of PAR denials, including members' appeal rights, are issued within 1 business day. So that is in regulation, will remain. Next slide, please. So Katie, I'm just going to hold comments for just a little bit because I want to get through a couple of slides so that we have time to get through everything, if that's okay. So this next comment here, change here, is actually just reorganized and clarified. The wording is reorganized and clarified. So the idea here is that services are provided between the provider's submission of the PAR to the URC and the final approval or the denial. They can be approved for payment. So this is just to clarify because we get this question a lot. If we provide services during the time that we have submitted the PAR Can we still get paid for them? And the answer is yes, you can still get paid for those. And so this language is really meant to clarify that piece. Next slide, thank you. Okay, so this one again is just reorganized and clarified. And this is when services are denied or reduced, that they will continue for 15 additional calendar days after the date of the member's notice of denial letter. One of the big changes here, and one of the things that I was been asked about repeatedly, is the rule currently states the date of the letter. Well, the date of the date the letter is mailed is what it says. It says mailed date, and that's really difficult. What do you, I mean, I've literally been asked, what are we supposed to do? Look at the postmark date? Fair question. That's a fair question. And so we removed that because it's too confusing, it's too messy. And so we removed the word mailed because it created too much difficulty in making sure that everybody understood. So we just said the date on the letter, so that is much more clear. So the 15 days is based off of the date of the letter, not the postmark date or anything like that, which is hard. And we'll go one more slide and then we'll start questions if that's all right. Okay, so this next one is actually pretty simple. These are just struck because this language is actually incorporated in the above language for simplicity. So what we did is we kind of condensed it down, included this in the other sections, and just took these out just to make it a little bit easier. They go together better and the flow is better. Okay, so there are at least 2 hands raised. John, you want to go ahead and start that?
Will do. So if you can raise your hand to get into the queue, and if one more time, if anyone right now is on the phone only and would like to speak, you can press *6 to give me your name right now for the queue. Okay. Seeing none or hearing none, we'll start with Katie, and then we'll go to Pam after that.
Thank you. Going back to the third, it's number 3, providers should only request services allowed or covered. I have some concerns about that because my understanding is that providers are not required to know what is allowed or covered under the PDN benefit. And I'm also thinking a lot about EPSDT, which is early periodic screening, diagnostics, and treatment for kids who are 21 and younger, or 20 and younger. You know, the whole point of EPSDT is, you know, the department even has a campaign where they're saying just ask, right? Ask for the care that you need, because there's a standard within EPSDT that it's not just to treat and diagnose, it's also to ameliorate. And so I'm concerned that putting language in here that says providers can only request what they think is allowed could actually restrict the options that may be available, particularly when you do the analysis under EPSDT.
Okay, that's super helpful feedback.
And then I had another one, if I may.
Of course.
I was actually curious with the stuff that was taken out and deleted. I'm not sure now what's happening with it. So like one question, number 7 was deleted, and number 7 was notifying the department of all extraordinary PDN services approved of an EPSDT screen. I'm wondering, will the department still be tracking approvals of PDN services based on EPSDT when they don't meet tech dependent requirements? I would love to see that be a requirement within the rule. And then also what's going to happen with expedited PARs. That's not in, if you're taking it out, I don't see it added anywhere else. And so it brings up questions of why we're taking things out, because then we don't know what's going to happen with those. And I will stop now.
Those are great questions. Thank you very much. And so Michelle, do you have any information on the expedited PARs?
Yeah, I was going to say, I was going to jump in, but because I'm so wordy, I figured you guys may want to hit the buzzer. Actually, I think that's a really good question. So I've written down the providers. Yes to EPSDT. Yes, yes, yes. I think, Candace, that's another phase, but yes. And when it comes to expedited, so I think this is worth a discussion, not so much here, but I think I'll give you some of the thoughts I were having, and then let's follow up with it. So the way it was written in this rule, it just says for expedited. And what I wanted to do is really pull that and start looking at where's expedited defined in our other rules, because I have expedited defined in my contract. I also have other categories. And I think part of the modernization of the program sent with the clinical team in the last year or two has been to have multiple categories. So I do believe, and please do not hold me to this, but this is what I'm thinking, is the expedited has like life or death. And to me, that's not going to fit. It may not fit with this. So what other categories can we do if that one legally or by rule or by definition? So I have actually created, in this new contract, I have created what's called a rapid review, which is, it's not expedited, it's not life or death, but we need to get them out of the hospital, right? So there's different categories of why we need the PAR done quicker than the current contract. So what I'm doing is outlining all these. This is what expedited is. Is it in rule? Where is it all defined? Are all the definitions confirmed? Hey, we don't think a lot of our PDNs are going to fall into that, but they may fall into a lesser definition, like I said, like a rapid or some of these. That's what this would be. So I want to bring that back as, again, really outlining these different definitions. Which ones do you all feel most likely align with your members who need this rapidly, urgently, expedited? And so anyway, that is a discussion we're having. We will bring that back. And I think that's what I'd really like to get some information on, whether or not you think I've captured those different categories well for this population. Sorry, Candace, is that?
No, that's super helpful on that. And Katie, we have noted your comments on the others, and we will make sure that that is in the listening log on where it is found, or if we just need to bring the language back. This is exactly why we bring this information forward. So thank you. John is facilitating, not me.
Yeah, Ken, you have one more hand raised. Pam R. Pam, do you have a comment other than, I saw your request about the organizational chart link. Is this a different comment question?
No, I wanted to comment on the change from of the 15 days.
Okay.
On calendar days. I think that's way too short.
Okay.
I currently have a letter that was issued by KeyPro on the 20th. It's the 27th, and I haven't received a letter. I only know that because, you know, my agency forwarded the letter that was given to them, you know, in a Trezo. However, even if you, let's say the decision is issued on a Friday, we've killed, and maybe the company doesn't pick it up until Monday afternoon. Like, that's already 3 calendar days out of 15. And then we've got, as a consumer, we have to be able to then find an attorney. We have to be able to speak to the attorney. We have to be able to get all the documentations to the attorney. Like, you don't just file an appeal overnight, right? And these are not children that you can just find a new daycare for, right? And so 15 calendar days seems a little short when previously it was 60.
Okay, so I appreciate that feedback. That's exactly what we're looking for. I do know the 15 days is what is currently in rule. And so your suggestion is 60 days?
Well, there's somewhere else when it talks about reimbursement. So these two things kind of contradict each other, because when you talk about reimbursement, it talks about reimbursing for services up to 60 days after that, you know, after, I'm trying to find it here. Because I remember seeing it and it was crossed out. Now I can't find it, of course.
I think it's up to 30 days. But regardless of what maybe is in a different section, what I'm wondering is what an appropriate time frame is. What is your suggestion rather than the 15 days? Because what I'm hearing you, and I see in the chat, Galia is also responding that the 15 days, and I think a couple other folks have said, I mean, 15 days is not enough time.
I feel like 30 days would be the absolute minimum.
Okay.
Because
so
we're not even getting these letters for 7+ days.
Okay.
Right? Like in the mail, we're not getting them. So you're writing the letter, like the letter that I should have in my hand was dated the 20th. It's now the 27th. I don't have it.
Yeah.
Right.
Okay,
So that's
great
7
points.
business days already that's gone. And that's assuming I check my mail every single day. Right. And so you can have somebody that doesn't check their mail but once a week because they can't physically get to their mailbox because it's down the street. Right. And now it took you a week to mail it, and then it took you a week, you know, to pick it up in your mailbox, and that now your 15 days is already gone, and you haven't even made a single phone call. So that's as a consumer, that's all I'm saying is that just seems a little short to try to start a legal process
Yep.
in.
Yeah, I appreciate that. That is really great feedback, and I appreciate all of those points because, yeah, you're right. My mailbox is only at the end of my driveway, and I can tell you I don't ever open it. That's apparently one of my children's job. But point being is, with how long sometimes the mail can take, and if you can't get your mail every single day, I think those are all really great points. I appreciate you bringing that up. And I heard you say 30 days minimum. I'd love to hear what other folks think. I saw Galia say 60 days. And so kind of between the 30 and 60 days is kind of what folks are thinking is more appropriate for this timeline. I see Deborah shaking her head yes. I can see you on my screen for some reason, so. Galia, is your comment about the number of days? Because I think I already have your suggestion here. Anybody else have a different suggestion for timeline? Okay, thank you. That is super helpful. We will certainly take note of that. And then I think there are a lot of comments in the chat box here. I will do my best to go through some of them, and then I want to get through, oh, there's a lot of slides. Some more slides here. Okay, so.
And Candace, just one more question. Does that 15 days account for the potentiality of asking for a redetermination or a peer-to-peer? Like, is that listed somewhere else in the process? Does that stop that 15 days if you initiate another process?
So typically determinations are not, and letters are not rendered until after that time frame, the peer-to-peer, the redetermination. So those all happen before that. Michelle just shook her head, no.
You know what? I think it's a good question. I don't think it does, actually. I think this is, you just pointed out something that I don't think we've ever talked about with Candace's team. Let's map this out, because I think it would be great to say determination, here's this clock. And I think this would be a great graphic, right? Termination, here's this clock. This is what the provider can do. Here's the 15, here's the mail, here's the ALJ. I want to make sure that we have this absolutely correct. So let's take it back.
Yeah, and also exactly to Pam's point of when, like, does the clock stop on this 15 days or whatever we determine it to be? Is it after? So I think that's a really great question. So thank you for asking that, and we will work on that. Okay, so going back to other things in the chat, there are so many comments and questions. We talked about the 15 days already. The continuation of benefits, Christy, is, I believe, and team, correct me if I'm wrong, later in the regulations. I hope nobody's shaking their head yes. So we will look at that, Christy, to make sure that is clear. The continuation of benefits is different than the 15 days that is outlined here. But obviously we have some work to do on the clarity of this 15 days. So I'm going to scroll past because there's no, the percentages in these denials are not accurate. Let's see here. Katie, you're chiming in on expedited part again. So we'll take that comment. More on the 60 days. Sorry, I'm just making sure I go through. We talked about the peer-to-peer, Chris, so we'll clarify that. Okay, and so Holly's question is around the term of may, so that claims may be paid during the time between the request is submitted and the decision is rendered. Is there criteria to determine when those claims would be paid and when they would not be paid? That's a really great question, and something that we need to clarify. And I think that there are times where the claims would not be paid, and sometimes that is if the member is not eligible for services, so that does happen. So maybe they're not eligible for Medicaid, then the claims are not paid. If there is a billing error, so if somebody submits a bill in error that is a clear error on the coding or whatever, that wouldn't be paid. Timely submissions. So there are certain instances we can look at perhaps clarifying that a little bit. Gaia, you're asking if an AG is representative during this process. They're not at the meeting, but the Attorney General's office reviews all of our regulations prior to them going to the Medical Services Board. We also have an Attorney General representative at the board at every single meeting. All right, so another vote for 60 days. So Chris is asking if the step down PAR is no longer going to happen. The step down process will still happen, and that is being outlined. We are posting that online shortly. More information to come on that. Thank you, Michelle. Sorry, I didn't see your response. All right. Made it through those. Let's go to the next slide, please. Okay, so thank you so much, Erin. So this slide here is, we are just striking the language because it is incorporated in the areas above, and striking this and incorporating it above makes it a little bit more clear and helps. Katie, you don't like that we struck this language.
I'm sorry, I don't. When I look at the draft, I don't see it incorporated above unless it's just incorporated in the contract. But I think it's important that, and I use quotes just to say, like, you know, again, as I've said, we don't have as much access to that as we do rules. When the utilization manager delays its response, the home health agency should not be on the hook for the days of service prior to approval. We know that that's happened. It's happened many times over the past several years. So I don't really quite understand why this language is being struck and then where it is now. Like, I think it's important that if KEPRO is behind, which we know happens, that the home health agency isn't on the hook because of their delays, which again, we know happen. And so I'm just curious, like, why is this being taken out and where is it?
Yeah. So the idea was that we added the language that payments will be authorized and will be made. And so the idea was that that kind of helps clarify, but I'm hearing you that it's not quite clear enough and that perhaps we need to take a look at some of this and maybe add it back in.
Yes, please.
Yeah,
Okay.
I think I hear what you're saying, which I didn't read it that way. That's really helpful, Kate, to hear it. So
Same.
yeah, Candace, I think it's, I think, yes. I think this is worth discussing because I heard it from your version, Katie, that I didn't see before.
Yeah, I appreciate that. Thank you. All right. And Chris, you have your hand raised for this one as well.
Real short, Candace. On a previous slide, you talked, this is from 8.540.7D, 1 and 2. You said providers must submit requests for their prior authorization of PDN services directly to URC within 10 business days of starting the PDN.
Mhm.
But then this one that just was going to be, that got moved past it, but the one that you're going to strike entirely just said that no dates will be paid prior to the date that the URC receives the PAR request. So I'm confused as to whether, like, PDN, they don't seem compatible to me. I'm not understanding something. Within 10 business days, but you don't get paid for those 10 business days?
So that's part of what this says. So if you go back to the slide where we struck the language, I think it's slide 16. So the first sentence here says no services shall be approved for dates of service prior to the date the URC receives a complete PAR. So that language is actually in conflict. And so that is part of why we struck that, because we gave you 10 days to submit the PAR. We then cannot go back and say that you won't be paid for those days. Does that make sense?
So Candace, yes, I think so. It's a lot of changes, actually. Let me just state this simply and see if I've got it right. So an agency has 10 business days from the start of their PDN care to get the PAR in, and then we'll be able to bill if everything is approved back to when they started the services, not when they sent in. So that's something brand new. That's kind of huge, it seems to me.
My understanding is that agencies have always had the 10 days to get their PARs in. And so that shouldn't be new, but hopefully it's a lot more clear.
Okay, maybe that's true. Thank you.
You're welcome. Thank you for asking. Okay, so the next slide here, I'm just going to keep us moving. And real quick, I see, Donna, your comment of language being struck because it is noted in another location should have a citation listing where we believe that language is. I think that's a really great point. Thank you for bringing that up. Erin, did you want to comment on that?
Sure thing. And thank you, everybody. I'm Erin Thatcher. I'm the supervisor on the home health team. We do have a red line document that's in the link that I put earlier. So it's on the private duty nursing page. And if you're a visual person like me, you might find it easier to read through. We do have to do this current and proposed for accessibility purposes, but I realize that this may not be accessible for you or easy to read. So I would suggest if you'd like to look at all of these in kind of a row, to please go to the website. I'll put the link back in the chat.
Thank you, Erin. Okay, so this one, this language here is actually being struck because it's outdated language. Go to the next slide. Also outdated language and added pertinent info in the above section, which is somewhere. Because I actually don't know exactly either without us citing it, but to Erin's point, the accessibility makes it difficult to put in little notes. There we go, thank you. Oh, I think that was supposed to be a link. So this one,
it's not a link, it's the name of the document that
that you put in there. I thought it was supposed to be a link. Sorry. So this one, if you all remember, this one and the, gosh, maybe a few after that. No, just this one where we talk a lot about the services and reinitiating the PAR process. That obviously has all finished. Those dates are done. We have moved past August 31st of 2022. It is April of 2023. I have no idea how, but magically it is. And so we took out all of this old language. All right, next slide, please. Reimbursement. This is a fun one, but it's important to make sure that things are clear. So I'll go through this slide really quick, Pam, and then we can get to your comment. Wanted to expand this one for clarification of daily hour limits per age. So this one is called out and separated by age. And so we didn't change B at all, but we adjusted A to make it much more clear that there is a difference between adults and children and how many hours a day they can receive. All right, Pam, you have a question.
So we just found that spot. So it's the previous slide that you did, 8.5, blah, 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 7G1. And then underneath that, it says when denied or reduced services shall be approved for 60 additional days after the date on which the notice of denial is mailed to the client. And you struck that. Yeah,
so that was because that was instituted solely for the reinstitution or reinstituting the PAR process. So if you recall, during COVID, actually during the peak of COVID, we turned off many of our PAR requirements because it was such a difficult time, and there was a lot of things that we were able to provide flexibilities on, and this was one of them. And so during this process of after having this type of service with no request requirement in place, and then turning it back on, we instituted both this timeline and that additional 60 days within that. So it was always intended to be temporary, the 60 days. But what I'm hearing you all say is that, I mean, obviously loud and clear, the 15 days isn't enough. And I've heard anywhere between 30 to 60 days. So I appreciate you finding that, but that entire section, as evidenced by the dates provided within it, was always intended to be temporary.
Okay.
But that's helpful. I appreciate that. And regardless of that or not, I think we've heard that the 15 days just doesn't make sense. And so I really appreciate that. And Galia, you have a question?
I do. Can you hear me?
We can. Thank you.
Great. This is Galia Spachelska. I'm an RN and FNP and a family parent caretaker, and I appreciate everybody's time. I do want to raise some concerns is that we are not reviewing some of the concerns and input and feedback from the last stakeholder meeting. There was no minutes of prior changes made. When I asked about the continuous, which had a lot of stakeholder objections, you stated to me that discussions were made at HCPF and this was the decision. And there was no information provided for that. And I have a really big problem with that because then that means that our attendance as stakeholders and our input is not really taken seriously. You have no evidence-based practice based on not taking continuous out. You did not share what these discussions were. Additionally, I had asked for the Board of Nursing, for clinical experts, for the Attorney General to have a representative here to answer specific questions. These are very, very serious policy changes, and we need to have an AG representative here to answer some of the legal implications for the wording. And lastly, I am truly appalled that HCPF decided not to separate pediatric and adult PDN, and that we're not back on track to some of the things that we were working on at the last stakeholder meeting, because that wasn't even done. It seems that you're just reading the slides, but you're not necessarily taking in the input, and then the last meeting's minutes and things that we didn't finish doing or discussing are not even brought back to the table. So I have some really, really huge concerns about input from the stakeholders, about discussions, about timing, about having an expert panel, and really doing the work, because it doesn't seem like this is happening at this meeting. Thank you for your time.
So thank you for that. First and foremost, one is we did hear your request to have somebody from the Board of Nursing attend these meetings. We have actually reached out and asked, and unfortunately at this point in time, we don't have a representative. I will also tell you that we have a lot of clinical experts already on this call. We have a lot of clinical experts that work within the department and that are a part of every single process that we do. Michelle, as she mentioned, has been a nurse for 30 years, and she is but one of our many experts that we have as part of this process and on this call today. The AG's office usually doesn't join stakeholder meetings. It is just a feedback process. They do not provide legal advice. They do not give out legal advice. That is not their job, and that is not something that they are able to do. So that is not a process that is usually, they don't come to stakeholder meetings. That is just not something that they can do. They cannot provide legal advice or legal expertise in any way. As far as the changes from the last meeting, nothing is final. So as I stated at the beginning of this meeting and at the beginning of the last meeting, nothing is final. These are all just proposed changes. We have not finalized anything at this point in time. We are trying to get through these sections, and then we can look through and incorporate all of the changes. We're not going to have a conversation and make changes and then have to have that conversation 4 more times and make those changes 6 more times. The idea is, let's gather all the feedback, make all of the necessary changes, put it back out to the public, and then typically what we'll do is, especially for something of this size, is we'll have another large stakeholder meeting where we go through the changes and say, okay, so this is what we heard, this is where we were able to make changes, this was not where we were not able to make changes, things like that. And then the only time anything is final is once it's approved by the Medical Services Board. Nothing is final. I also did not say that we were discussing internally about the difference between the continuous versus continued. What I said was that we received a lot of feedback and it was contrary. We received support for continuous and support for not continuous. And so at this point in time, that is not something that we have made a final decision on or agreed upon to move forward or not move forward. It is part of the overall feedback that we have received. We will continue to take a look at that feedback and incorporate it.
Candace, are you there? This is John Barry, folks. I'm just checking in. Aaron, do you show Candace still in the webinar? Apologies, folks.
I think she's frozen, John.
Okay. I was going to exercise my diplomacy skills and ask her about the balance between, these are important conversations, and also getting through some materials. So I'm sure she's scrambling to figure out.
John, while Candace is frozen and while we're trying to get her back online, I'm just going to do a little bit of housekeeping. So we have about 20 minutes left of the meeting. We still have some information to go through. I'm going to put links in the chat again. If you have not done attendance, please fill that out and let us know that you're here. So give me one moment here. And then The other thing that is really helpful, although we are collecting all of your verbal comments and comments in the chat, like we are documenting all of this and keeping it for our records, we do have a feedback form that you can use to provide additional information. So I'm going to put that in the chat again, that link. Hopefully, oh, let's see, attendance link and then the feedback form. All right. Thank you, John.
You bet. And everyone, I just want to suggest, not sure how this is going to work out with Candace's presence in the meeting. So if there are things that you want her to quote unquote hear, if you can put them into the chat right now, she will see
Hey
them.
guys, yeah,
We'll make sure that she'll see them.
hey guys, this is Christy, and her internet dropped. So
Okay, thank you,
she texted me that her internet had dropped. She's
Oh.
trying to get back online now.
Okay, thank you. So again, not sure the outcome of that as to whether she'll be successful. But if are there things that you want to make sure that she hears? Seems like Galia might have a response in turn to what Candace was saying. Galia, if you want to type it in, that will certainly make its way to her for sure.
Okay. And John, I can take slides from here if that works for you.
Absolutely. Thank you. Go.
Okay, thank you. So Candace had just started on this reimbursement slide. And so we do have the clarification on aids. So we put that in here. And I want to thank Katie for the client piece. We did get that feedback and we'll make sure to update that. Okay. The current rule, we've got information about the ERC and submitting claims to the fiscal agent about billing, really just updating terminology. So members benefit rather than clients.
Thank you, Erin, for jumping in. Apologies. I'm back. My internet dropped. It's how it goes, right? It always has really good timing. Okay, so we are on slide 20. Thank you so much for jumping in, Erin. I really, really appreciate it. I think we have some questions. Let's go ahead and go through one more slide here. The next one, no changes. So that's exciting. This is a nice, easy one. Okay, so we've got a few more slides, but let's go ahead and pause for a couple of questions.
Okay, folks, this is John Barry. So I am setting up names for the queue. You can raise your hand in the webinar. And if you're on the phone only, you can press *6 to unmute your phone right now. People haven't been doing that today. Most people are online. That's a good thing. Okay, let's start with Galia and then we'll go to Christy Blakely.
I wrote my comment.
Okay, thank you so much, Galia.
I'll go ahead. John, I'll go ahead and read that if that's all right. Okay. So I guess there's nothing for me to respond to on that. Thank you, Galia. We have a note of that.
All right, Candace, thank you. Christy, please go ahead.
I'm asking a clarifying question on the definition of medical necessity in this rule. Which one are we using? Are we using EPSTT? Are we using which one?
That is a good question, Christy. Thank you for asking that. Team, we have that outlined.
I thought we were, my understanding is, yes, we're working with our legal team too to look at all the EPSDT stuff. So yes, we are going to reference that, but Christy, I think we're bringing that back when our legal team makes sure that everything is where it's supposed to be. That's my understanding. Does anybody else disagree? Christine or Erin?
All right. Thank you, Michelle.
Thank you, Michelle.
So Candace, that's all for the queue for the moment.
There's I don't have access to all of the comments anymore since my internet kicked me out because we're not friends right now, I guess. But I do see a couple of comments where Shannon has a question around final decisions for the last remaining families. So that's a process. Shannon, if we have time for those questions around kind of where we are with the administrative approval process, we can certainly take those at the end, but I want to make sure we have time to go through all of the things specific to the rules for this meeting, which is the point of this meeting. But I appreciate that. All right, let's go to our next slide here. Okay, so this particular change here was reorganized and meant to provide some clarity. So as you can see, we brought it down into some bullets of the one where it talks about the units of 1 hour can be billed for an RN or LPN, just to kind of provide some clarity of what a unit is and whether it can be an RN or LPN. All right, next slide, please. We are now
Candace,
making really good progress. Oh, yes.
2 and 3 are the next ones here. So go
Oh,
ahead.
thank you. Sorry, it looked the same. That's why. And then as we mentioned, we reorganized it and provide some clarity. So to make it a little bit easier to read, we had it bolded out to 1, 2, and 3. So here it talks about the RN group rate should be utilized when a nurse is providing services to more than one member. So this should be member instead of client. We'll take note of that. Katie, I saw one of your notes earlier that we missed that there as well. So thank you. And then the same with LPN when you're providing services. So we do allow a group rate for private duty nursing. Next slide, please. All right, so this is going to be a, I believe, likely robust conversation, which I'm actually really excited about because it's helpful to have the perspective of everybody. And for those that are actually, on the front lines of providing these services. So there, number 4 says that blended RN LPN rate is used as a group rate by request for the home health agency only. And so this is for when one nurse is providing services for more than one member. What we don't currently have outlined in our regulations is what is a group and what is the limit of that group. And so I think we can all say that we should have some limits here because these are medical services. These are highly complex individuals that are being provided care. We don't want to say that one nurse can provide care for incredibly complex, medically necessary, medically needy actually individuals, for like 20 people. Like nobody's doing that. But the point of the hyperbole is made, right? We need to make sure we have some parameters around what is safe and what is not safe. And so while we understand that oftentimes there are multiple individuals that live in a home and it's feasible to provide care to multiple people at a time, and that's great, but what is that limit? And so that's one of the conversations we wanted to bring to you all and ask you of what is your perspective? We have research from other states. We know that several states use a 3-to-1 ratio as their max. Several states use a 2-to-1 ratio as the max. We actually like the idea of the 2-to-1 ratio, but really wanted to get your perspective on that. So John, at this time, I would like to actually open it up to ask for feedback specific to what individuals feel is an appropriate ratio for this type of care. And remember, this is a very complex, highly invasive service.
Very good, Candace. So this is John. If I read it right, we have 10 minutes left. So I'm just adding to what Candace said to say, if you haven't spoken yet, we'd love to hear from people who we haven't heard from yet. So, maximize the voice here. So please go ahead, raise your hand if you have a comment. Let's see, Deborah Bowman, go ahead.
Yes, I've been a pediatric nurse for 20 years, and I'm currently the nursing supervisor with All for Kids Home Health. I think certainly that the ratio should be similar to what we would provide in a hospital or facility with similar acuity kids. So I agree, we're probably looking at a maybe 2-to-1 ratio, depending on the acuity of the child. But I think we can look to some of our expertise with some of the ratios that are already established for caring for patients of similar need.
That's helpful. Thank you, Deborah.
Thank you. Pam, please go ahead.
So I think that this is an incredibly loaded thing because, as you all know, in hospitals, they have ratios that are exceeded probably on a daily basis based on the number of nurses that they have. If you look at a nursing home, you've got nursing homes that have a ratio of 20, 30, 40 people. It's how it's laid out, right? And so I think that to put an exacted number is doing the community an incredible disservice, because you're not looking at, if you're going to look at this from a perspective of individual needs, and all of these children are only going to get approved based on individual needs, like you can't, you know, currently right now in my home, I have 1 nurse to 6 kids. I also have 2 teachers and a therapist and a CNA. Like, so to put an exacted number on it is going to be incredibly limiting, 1. And 2, you're not going to get, we don't have the nurses. So when you look at a hospital doesn't have, do you know what I'm saying? Like, they're not, if they don't have a nurse and their normal ratio is 2 to 1, but they don't have enough nurses for that, their ratio that day becomes 4 to 1 or 5 to 1 or whatever they have to do to protect, you know, to take care of that patient. So I think that with home health being so individualized, to put an exacted number on it is going to be incredibly problematic for the kids that are currently in care.
Thank you for that.
Because
feedback,
we're not,
Pam.
are we talking about nurse to adult or nurse to patient? Are we talking about child to adult? I mean, because right now I probably do have a 2 to 1 ratio in my house.
Yeah, that's helpful.
It's not nurse to child, right? It's not nurse to patient. It's more adults. I've got 2 therapists, 1 nurse, a CNA, and 2 teachers in my house right now. I don't need 3 more nurses in my house right now. That would be a waste of resources.
That's helpful. Thank you, Pam. That's something for us to look at and consider for sure.
Thank you, Pam. This is John. Candace and Aaron, just want to point out the time, and not sure what you need in the way of time for wrapping up, next steps, etc. We're just about at 5 minutes.
Yeah, we have just about next steps in a wrap-up slide, so we're okay to take a few more comments.
Very good. Galia, you're up next in the queue.
Hi, thank you so much. This is Galia Spachelska. I'm an RN FNP. And I just want to say that in my 25 years of experience and probably about 16 of years of it in inpatient, mostly in the ER, I really express a lot of concerns that Colorado State hasn't even done hospital inpatient ratio legislative work, and capping that at 3 to 1 is quite dangerous, because there are multiple, Casper, I'm on the phone, sweetheart, I know. There are multiple barriers to that. We currently have a huge nursing shortage in the pediatric home health arena. And I mean, I haven't had an extra nurse for 3 years, and post-pandemic, and the ARPA funding was not used for nursing shortages in pediatric home health. And so I worry that capping that would decrease our pool of nurses, decrease our quality of care, decrease our access to nurses, and would therefore deny access of safe nursing care to our kids, some of whom there's a mixture. If you have more than one client, some are more acute than others, and that's all based on most hospitals' nursing ratios. In pediatric hospitals in the state of Colorado, like at Children's Hospital, some of their step-down units and regular floor patients are 4 to 6 to 1 because they don't have the nurses to staff it. I just really have a lot of concerns about putting an actual number on that, because there's just not enough nurses to go around to begin with, and this would restrict access. Thank you so much.
Thank you for those comments, Galia. I appreciate that. I think considering the workforce shortage is critical and important, and a component that we absolutely need to think about as well. So thank you.
Anyone else for the queue at this point? You can raise your hand in the webinar.
Candace, just in follow-up, I do want to add also is that when we do have, you know, more than 3 patients at home, you know, having additional alternative access to different appropriate providers where an RN can delegate tasks can be intertwined into this rule somehow. But I think it would be an important additional benefit. Like, let's say if you do want to put those numbers, then you can say, you know, we can do 1 RN, 1 CNA to every 5 kids. But again, I think putting out those numbers is really, really destructive to our process, which is to really help ameliorate and maintain our kids at home so that they don't have to be inpatient. That's just another thought process.
This is John Bear.
Thank you, Galia.
I'm going to stop, if I may, and just see if there's anyone that we have not heard from yet today with respect to everyone we have, because we have just a few minutes left. Anything else that anyone who hasn't spoken yet would like to say?
Hello.
Okay. Hearing none.
Oh, John, I think somebody's trying to talk that's on the phone.
Hi.
Oh. Who's that on the phone?
Hi, my name is Anna Barisi. I'm an RN, parent-child. I just was wondering if the criteria is going to be clarified. I see on the website it says technology dependent and some other bullet points, but is that something you're still working on? The criteria / assessment tool.
Yeah, so currently what we have worked on as far as rule revision language changes is specific to the PAR process. The other pieces of the regulations around, you know, criteria and things like that will be for future meetings.
Okay, thank you.
Thanks, Anna. So glad that you hopped in there. That's great. I have that we have a minute left or less, Candace, right now.
The time does say until 11:20, but we tend to go over that. But let's go ahead and move forward. I appreciate all of the comments. Thank you for continue to add them in the chat box. Those are super helpful. They will all be logged and posted as we move forward. So the next steps, we will have future engagement opportunities and meetings. All of the documents and recordings are available on the private duty nursing website. Erin has posted, we have a feedback form. She put that link in there for me. Thank you so much. And then also obviously the email inbox that is monitored every single day. And we try to get back to those comments as quickly as possible. There's lots of different ways that you can submit feedback and comments to these rules. You guys brought up some really excellent points, and I really appreciate it. As you go through, if you see other things, please throw those our way as well. Again, this is a process, and we really want your feedback, and we are documenting all of the feedback. And so it is really important that you continue to provide any sort of changes of, you know, as an example, Katie saying, I don't think you really, you know, hit the mark there with that change. Great. I appreciate that. That's exactly why we wanted to present it to you all. So thank you for that, and continue to provide all of your comments and feedback. So Galia, that's a good one. Sorry, I saw that around the transferring because I've read that comment so many times. There's been many comments, and we actually are looking into that and trying to figure out how we could potentially do that in the future. So thank you so much for that. And that is actually on the listening log that will be posted shortly. Again, other ways to provide your feedback: email, you can fill out the form, you can fax it to us. If anybody still has a fax machine anymore, I'm not sure. You can write a lovely letter. And they will make sure that we get a copy of that. So whatever is the best way for you to be able to submit your feedback, please do so. And we are accepting it in any way possible. Next slide, please. So let's go, yeah, I was gonna say, let's go 2 slides. So there's our contact information. If you have, if you could go back just one more, sorry. Questions about this process, about these rules, just in general, please reach out to the home health inbox. We have, like I said, a lot of folks that check that inbox and provide responses. And lastly, I will thank you all so much for coming today. We really, really appreciate your time. We really appreciate your feedback and your willingness to engage with us. It is important. It is how we are going to improve things and make things work for all of us. So thank you so much. Thank you, Pam, for that additional last minute comment as well. I hope you all have a wonderful rest of your April, what is left of it, which still blows my mind because I didn't even realize it was April. Thank you all. Take care.